All right, well, I'll go ahead and get us started here. So, hi everyone. My name is Blair Arrett. I'm a clinical psychologist at the San Diego VA, and I'm really excited to be here today to talk with you about a feasibility and acceptability trial of an intervention that I developed called Caring Cards. Just a couple things to note before we dive in. So, all of the artwork that you see in this presentation are actual cards that were made by veterans as part of Caring Cards. The second piece to note is, as you know, we don't have a ton of time today, so I'm going to move pretty quickly. However, we published the results of this study, so if you miss anything or you want more information, I recommend that you check the paper out. The main citation is listed on my reference slides. All right, we'll go ahead and get started. So I'm confident that everyone here is well aware that veteran suicide is a significant problem, and it's a top priority for the Veterans Health Administration. We know that veterans are particularly vulnerable to suicide in the 12 weeks following discharge from a psychiatric hospitalization. And I'm sure many of you are also familiar with a widely used and low-cost, low-demand suicide prevention intervention called Caring Contacts. If you're not familiar with Caring Contacts, they're preformed messages of hope and support that are typically sent by hospital or research staff to individuals following an acute suicidal crisis, like an inpatient stay. And these messages have been studied in various forms, like letters and text messages, along with a lot of different populations, including veterans. And although there are some studies that have shown some mixed outcomes for Caring Contacts, it's generally empirically supported. And so for those of you that also work in the VA, like me, you may also be familiar with peers involved in mental health recovery. So peers are individuals with lived mental health experience that are trained to use this lived experience to instill hope and empower others on their recovery journeys. And the integration of peers in mental health is widely used and supported within VA, and their involvement in mental health care actually demonstrates some pretty positive outcomes. And finally, I wanted to just acknowledge the interpersonal theory of suicide and everything that it's taught us about the importance of social disconnection and its role in suicide risk. So what is Caring Cards? Well, Caring Cards is actually an integration of Caring Contacts and peers. And although it's referred to as a single intervention, Caring Cards encompasses two sub-interventions. So one would be a card-making group, where veterans with lived experience meet and they create one-of-a-kind handmade cards that are filled with hope and empowering messages that are then, second sub-intervention, actually sent to veterans who are in need or at risk for suicide. And in this study, those we're talking about are folks who are recently discharged from an inpatient psychiatric stay. So Caring Cards is quite unique in that it simultaneously targets two clinical populations that are at risk for suicide. So as I said at the very beginning, we're looking at feasibility and acceptability. So our aims were to establish that within Caring Cards for both of the populations that Caring Cards addresses. So our card makers here, just to kind of give you a lay of the land, these folks were all outpatient veterans who were receiving VA mental health care. They were all included from a specific clinic, and all were diagnosed with a primary psychotic disorder and significant functional impairment as determined by a global assessment of functioning score of a 50 or below. These two pieces were requirements for eligibility to receive care in that particular clinic, not specific to the study. For feasibility portion of looking at the group, we examined 32 veterans, and for the acceptability portion, we looked at 7. For the card recipients, these were all veterans from our VA that had an inpatient stay and were discharged within this 2-month time frame here. They had to be admitted for suicidal ideation or behavior to be included in this particular study. And at discharge, they had to have had a viable phone number and mailing address. And for the feasibility portion, we looked at 78, and for acceptability, we looked at 18. So I'll give folks a minute at this very busy slide to see these were some of our sample characteristics here for both our card makers and card recipients. For those that are curious, the average age for our card makers was 49, and the average age for our card recipients was 45. So moving into our procedures. So for our card making groups, veterans met on a weekly basis for 90 minutes for 18 months. The groups were facilitated by a variety of different VA staff or trainees that were associated with the home clinic. And the training and education of these folks ranged anywhere from bachelor's level to doctoral level. The groups were very, very free form, and minimal guidance was provided to the veterans. The only thing that they were really instructed or encouraged to do was to make the cards that were basically going to be neutral to anybody who received them. Since we kind of randomly selected and sent them out to people, we didn't know who were going to get certain cards. We wanted the veterans to make a card that any veteran, regardless of their branch or their religious affiliation, their political beliefs, could pick up a card and feel connected to it. They were very much the creative decision makers of the group, and often focused on their lived experience to really make these cards and instill that hope and empowering messages. And quite often they would naturally, and we also a little encourage them to collaborate on making cards. So this card that you see here is a great example of that, where we had one very artistically inclined veteran who drew the beautiful image that you see, and another veteran who fancied themselves more as a wordsmith was the one who captioned this card. So this was actually made by two veterans. What you can't see here pictured is that at the bottom of each card, there's a message printed that says designed and created for a veteran by a veteran. And as I might have mentioned before, we do have a manual that you can download online for free. And if you'd like to learn how to make this group something in your own clinic, you could definitely take a look at that or just contact me. So with that said, then moving over to our procedures for sending our cards. So we mailed one card approximately 1 week post-discharge, and we included a letter explaining why they were getting this card. A doctoral level provider then reached out by phone about 10 days after the card was mailed and invited them to provide some feedback about their experience receiving the card over the phone. So to drill down a little more with our feasibility and acceptability, for the groups, we were looking for feasibility at our group attendance rates. For acceptability, we were looking at some open-ended feedback that we solicited from group members at 2 different time points. For sending our cards, we looked at things such as the number of veterans that were actually eligible to receive a card, those that we were actually able to reach for follow-up, and then of those, how many were actually willing to provide us with follow-up information. And our acceptability then is based on those follow-up interviews with those card recipients over the phone. So our results. Takeaway message here, Caring Cards was found to be feasible for both outpatient veteran card makers and those that recently discharged and received the cards. For our group, our attendance rate was significantly higher than the average attendance rate of other clinic groups during that same 18-month period. And overall, for sending the cards, we did see some pretty nice numbers here related to 60% of veterans meeting criteria for eligibility to receive a card. Of those, we were able to reach almost 70%. And among that, about 50% provided us with feedback about the experience of receiving the card. In terms of acceptability here, we can see that Caring Cards was also determined to be acceptable for both groups of folks that were involved in the study. You can see here we had overwhelming support for the group. Like 100% of people were saying that they wanted the group to continue. It had a positive impact on their life. And even looking at our card recipients, 100% said the card receipt was positive. Many would like to receive more cards. They all think the VA should continue to do this. And a lot of people said that this was something that really positively impacted their experience following their discharge. So the next couple slides, I've pulled out some kind of notable quotes here from our card makers and card recipients. And so starting out with card makers, you can see here, these were some open-ended quotes that we got during our feedback sessions. And we see themes of social connection, appreciation, and even just the experience that making the cards really helped them in their own recovery process. You can see here for our card recipients, similar themes of being connected, right? Feeling cared for, feeling accepted. One person said that they are going to keep it on their fridge and they're going to read it again to give them more reassurance. And I think of these, one of the most moving ones for me is the one in the center when someone said that this card was essentially life-saving to them, and that's pretty powerful. So just in kind of summation and to wrap up, the Caring Cards program is a low intensity, it's feasible, and it's an acceptable intervention. It's very low cost and highly scalable. It's the first intervention to really combine peers and caring contacts within a VA setting. And what's unique is that it really just targets these two populations simultaneously. I also want to highlight that it was developed with veterans with psychosis. And that's not a common thing that you see in intervention development, or even including folks with active psychosis in research trials, and even specifically suicide prevention intervention studies. So that was a really special aspect to this study as well. Of course, there are definitely quite a few limitations to the study. So just to highlight a couple. So, we weren't able to reach every card recipient to get their feedback. As you saw, we were able to get about 50% of those that we were able to reach. It's possible that the other half might have said maybe not as favorable or positive things, but we really don't know. So that is a big limitation. In addition to that, we did not consent our veterans leaving the inpatient unit to receive these cards, but really the consent came when we contacted to see if they would be willing to provide that feedback. So it's possible our outcomes could have looked a little bit differently if we had obtained consent prior to sending out the cards as well. So they would have expected those or anticipated it. Of course, as I mentioned, this was all a pre-pandemic situation. So we don't have any information from this particular study on what those Caring Cards groups might have looked like if they had been converted to virtual groups. And of course, there were no suicide-specific outcomes evaluated in this study. And so we can't speak to the impact that Caring Cards has on those variables. We definitely know that more research is needed to determine if this is an effective suicide prevention intervention. Future direction. So fortunately, I was able to secure and be funded through the VA for a 2-year pilot study looking at Caring Cards. And in fact, we're actually wrapping up data collection this next month, the beginning of next month. And so we'll have hopefully some really interesting data to share at our next conference. And I will say, we did, of course, do it during the pandemic. So we have some actual virtual group data, which will be really interesting to look through. So with that said, thank you all so much for your time. Here are my references, just to draw your attention again. The main paper that this presentation is based off of is listed at the top. Other references are noted below. And I really appreciate your time. Here's my contact information. And if you, I guess I'll just stop sharing. And if you guys have any questions, we can kind of go from there. All right. Thanks, everybody. I appreciate the chat. Looking through something. So great question, Amy. So wondering if this be feasible to do with adolescents. I definitely think that it would. I, in fact, think that adolescents would probably really love this just because of that creativity aspect, especially in that ability to connect socially. So I think it would be a great project for folks to take up. And it looks like Nick or Nicholas, you agree with that piece. So yeah, would love to collaborate with anybody doing this with adolescents. Great. Well, thank you all so much for your time. I want to be respectful of my next presenter. So I really appreciate it. And please feel free to reach out if you want to collaborate or have any other questions. I love thinking about this stuff. So take good care. Enjoy the rest of the conference.
Mark, I think your team is up next, right?
Mary Grace is getting ready to go here.
Okay.
Mary Grace looks muted. Mary Grace, can you try to talk? I think you might have been turned on.
Am I now okay?
Yep.
Oh, great. Okay. Let me just go ahead and share the version. Okay. I think we should be all set, but somebody, Dr. Rieger, let me know if for some reason you can't see the slides or hear me. So my name is Mary Grace Laver. I oversee program evaluation and research at the Veterans Crisis Line, as well as our graduated intervention menu, one of which is the VCL Caring Letters Project, which we'll be talking with you about today. Before we start talking about that, though, let me turn it over to my co-presenter, Dr. Rieger, to introduce himself, and then we'll keep going.
Yeah, my name is Mark Rieger. I'm Chief of Psychology at VA Puget Sound and Professor of Psychiatry and Behavioral Sciences at the University of Washington. And as we get going, I just want to acknowledge all the authors on this slide. Really important team contributed to all of this.
Absolutely. So we're going to be talking about the development of the Veterans Crisis Line Caring Letters Suicide Prevention Intervention today. And like Dr. Rieger just highlighted, it took a village. So we have a whole host of people that have really been involved in both the implementation and evaluation of this project. Dr. Rieger does have a query-funded partnered evaluation for this project and his PI, but we have a qualitative team, Dr. Landison team, and a quantitative team, Dr. Garrido and team that are part of this project. And then certainly we've got the implementation team, of which I am a part. And so a large team to sort of make this project happen. Today we'll be talking about an operational overview of the Veterans Crisis Line. So who are we and what do we do? We'll review the caring context, methods, and background, and then we'll outline the ongoing VCL Caring Letters project and share some initial metrics and qualitative findings. So a little bit about the Veterans Crisis Line to get us started. So we launched in 2007 with phones only in Canandaigua, New York. And the Veterans Crisis Line really serves veterans, active duty service members, and then families, friends, or third parties that might be reaching out or contacting us about veterans or active duty service members. In 2009, we moved from only phones to bringing on online chatting and chatting options. And then we moved into texting in 2011. And so we began to sort of bring online these other ways for veterans, active duty service members, or third parties to connect with us. In 2016, we opened our second call center in Atlanta, Georgia. And then in 2018, we opened our third call center in Topeka, Kansas. In 2020, with the onset of COVID, we moved to a fully virtual workforce, and we remain a fully virtual workforce today. In 2020, we also launched the VCL Caring Letters Project, which I won't get into for the purposes of this slide, but we'll be talking about on the remaining slides. So we'll certainly dive more into that. The Veterans Crisis Line, since we opened in 2007, we've taken over 6 million calls, answered over 730,000 chats, over 250,000 text messages, and sent over 230,000 dispatches of emergency services. We've also sent over 1 million referrals to suicide prevention coordinators that are stationed at every VA medical center across the country. And so we send those referrals to link veterans to care so that they can engage through the suicide prevention coordinator and care at a VA medical center across the country. So in 2020, Claire Hanneman, Dr. Hanneman, and Dr. John McCarthy at SMyTrek in Ann Arbor, Michigan, was doing some evaluation work looking at identifiable VHA using VCL callers. And what they found was that identifiable VHA using VCL callers were increased risk of death by suicide with a rate several times higher than that of the general veteran population. And so when we learned about these data at the Veterans Crisis Line, we thought, what more can we do to prevent suicide among veterans that call VCL? We know what we're doing on the call, we're doing well. And I would turn your attention to some recently published work by Dr. Peter Britton, where he found that we successfully decreased distress and suicidal ideation over the course of the call. So we know what we're doing on the call, we're doing well, but what more can we do before, during, or beyond the call? And from that came this initiative, the Caring Letters Initiative. We call this our first Beyond the Call initiative, where we continue to support and engage veterans beyond the call. Dr. Rieger, I'll turn it over to you.
Thank you. So the previous presentation did a wonderful job setting the stage for our presentation. So I'll be able to save a little bit of time here. Caring Contacts was first developed in the 1960s and 70s by Jerome Motto out of San Francisco. Interestingly enough, he developed it out of his experience in the military. During World War II, he was deployed to Europe and noted the impact that letters made on his own well-being even from people he didn't know that well. And so out of that, he developed an intervention that has been described. The prior presentation was such an innovative example. Typically, they're messages that are sent 8 or 9 times over the course of a year, with caring messages that really don't ask for anything from the recipient, just communicating that we care, and if you need anything, we're here for you. Next slide. There's been a number of clinical trials at this point, and like many bodies of research, the results are mixed. There's been successful trials, and there have been null trials, and there have been mixed trials. Some results significant, some not significant in the same study. The VA DoD clinical practice guideline team took a look at the evidence with an independent and rigorous look at the quality of the evidence, and made a recommendation that the VA and the DoD consider carrying contacts after individuals are discharged from a psychiatric inpatient unit for suicide risk. In addition, and relevant to this presentation, in the Surgeon General's recent call to action, there's a recommendation to consider carrying contacts in more diverse settings where transitions in care may be problematic, including after a crisis line call. And so on the basis of this body of work, this project was born. Next slide.
Okay, so I'll talk a little bit about sort of the details of our project and what we did. So this is the largest caring letters project to be tested to date. We at VCL began mailing letters in July of 2020. And in the first year that we launched, we mailed caring letters to over 100,000 identifiable VCL callers. So really incredible volume in terms of the caring letters, the unique veterans that we're mailing these to. And then in a couple bullets, I'll talk about the actual amount that we're mailing, which is really remarkable. We mail 9 letters over 12 months. So we mail at months 1 through 4, 6, 8, 10, 12, and on Veterans Day. Our letters are templated, and the veterans are either randomized to receive a mailing from a peer or a provider signatory. And those are real, it's a real peer and a real provider that weighed in on the content of the letters. Our intervention was vetted through subject matter experts and veteran advisory groups. So this was both the letter content was vetted through those groups, but also the look and the feel of the letters, which I'll show you on the next slide. To date, we've mailed over 1.3 million letters to over 175,500 veterans, and over 72,500 veterans have completed the full 12-month intervention. So really remarkable volume in terms of the caring letters that we're sending and the volume of veterans that we're engaging with this intervention. So this is an image of an actual caring letter. You'll notice that there's a resource card. We do insert this double-sided resource card into every single mailing. All of the envelopes do have this same, they're the same color and same look. And as well as the postcard or the mailing that gets inserted into the envelope, it has the same border and the same seals in it. You'll notice that this one is from Mario, who is our peer signatory. A little bit about lessons learned from the implementation of our intervention. So we did learn that including a centralized phone number on all of the mailings was really important to give veterans an opportunity to engage. We picked VA 411, which is a resource that veterans can engage that provides sort of a whole host of resources for them to engage with, one of which is the Veterans Crisis Line. We do engage a secure and destroy program that the USPS has. So you'll notice, going back here to the image, that the return address is actually not a return address on our envelopes, it's the VA seal. And the reason that we have that is that we engage this project or program that the USPS has, where any bad addresses, any mailings that went to bad addresses are securely returned to a central USPS area. And then those mailings are securely destroyed by USPS, and we're sent a list of all the bad addresses so we can update our files. We do have a central email group for opt-outs and for feedback that's provided by veterans or veteran providers. We do have a tracking process for our reach metrics. So those metrics I just mentioned to you about the number that we're mailing to and how many we've mailed. We do have algorithms based into our data files. So you can imagine doing things at this volume would require built-in code and systems and algorithms to be in place in order to mail at that volume. We do have an administrative staff that does check our data files manually every single week for data files, or excuse me, for oddities before we send those data files to the vendor for mailing. And we do screen all of our files every single week for mortality to ensure that we're not sending mailings to a veteran that might be deceased. Dr. Rieger, I'll turn it over to you.
It's going to be really important for us to look at the quantitative data. We are planning to look at the effectiveness of the intervention. The intervention is still in progress, although finishing up with the evaluation cohorts. So we're really excited in the coming months to start looking at that quant data. We have completed some qualitative evaluations, though, so we want to share some of those results with you. We had a PhD level anthropologist and her qualitative experts conduct key stakeholder interviews with 31 randomly selected veterans who were at least 6 months into the intervention. And they code for themes that the veterans are reporting during those interviews. And you can see some of those on this slide, as well as representative quotes to illustrate those themes. So overall, we heard about themes that you would hope to hear about in a Caring Letters intervention. Veterans state that they felt appreciated and cared for and supported. Really important mechanisms. One veteran said, I felt wanted and appreciated. It's something I can go back to if I'm in crisis. It feels like there's someone there I can talk to. We did a lot of pilot work before the intervention was developed, so we knew that very few veterans find these kinds of caring contacts aversive. But when you do run into that, it's the kind of thing you see in this bottom quote, you know, are the cards really sincere? Does the VA really care? The veterans appreciated the characteristics of the intervention, the frequency, the timing, the look and feel, the greeting card kind of envelope. So that supported our pilot work too. Next slide. The signatories, you recall there's two. This was interesting. The veterans, many of them didn't remember who they got the caring contacts from during these interviews, but they remember how they made them feel. And I think that's really interesting and maybe important for the development of these interventions. Many veterans reported taking actions in response to the receiving the caring contacts. So they might have used the resources or accessed care. Here's a quote. I actually did use one of the resources because I was able to get a counselor. It's actually in the health community because I'm in a rural area. I'd just gotten out of the military. Next slide. So the results clearly support the tremendous reach of this kind of public health intervention. The data we have suggests it's at least neutral, if not acceptable. We didn't mention this, but the opt-out rate is exceedingly low in the first year. It's less than 0.5%. And the effectiveness data is going to be important. We're looking forward to analyzing those data in the coming months. So I think we can stop there, and we'll look forward to discussion after the other presentations.
All right, well, we can go ahead and keep going. My name is Samantha. I'm a clinical psychologist and postdoctoral research fellow at the VA San Diego and the University of California in San Diego. And this is one project that my team has been working on to look at the predictive importance of social contacts on veteran suicide safety plans. And this is my disclaimer slide, just that all of the views are my own and of my co-authors. A little bit of background here. As Blair mentioned, suicide prevention is a top priority issue for the VA. And I want to think to this concept of direct suicide-focused interventions, which when I'm using that term, I'm really focusing on those interventions that are directly targeting suicidal thoughts and behaviors. So not an indirect intervention like a diagnosis or other symptoms. And because direct interventions have been shown to be more efficacious in treating suicidal thoughts and behaviors. And this graphic up on this slide is showing our kind of broad standard of care that we have in the US primarily, and specifically also within VA. And so really what we're trying to do is figure out who these folks are that are at risk for suicide, assess them. And there's been a lot of great talks about how we can do that correctly and appropriately. And then intervening with them, such as creating a safety plan, which is the focus of this talk. And safety planning usually is including this concept of means reduction. So making that environment safe, and then caring context, which now we've heard a lot about. So another really important way. And that these are all suicide focused. And so I want to talk a little bit more now about safety planning. So you can see on this slide here, this is kind of an informational sheet from VA that's explaining the 6 steps of safety planning. And I'm not going to go through everything specifically, but what I want to call out here, and you can see that are circled in red here, are the 2 steps that are specifically related to engaging your social contacts in safety planning. So a provider and a veteran are going step by step through creating this individualized plan. And when they get to step 3, they're identifying who is going to distract you when you're in a crisis, or how are you going to decrease your isolation? Let's list those people down. And then the next step in step 4, who are these social contacts, family members or friends that can offer help? So this might be someone who you can talk to about your thoughts about suicide, or maybe that's someone who drives you to the emergency department. So really important concepts, and safety planning is a VA recommended and mandated tool for veterans at an intermediate or high risk for suicide, but they also receive safety planning in other situations, like being discharged from an emergency department at the VA or after a psychiatric hospitalization. So interestingly, though, given how wonderful this intervention is, there are really few efficacy trials for such a widely disseminated and standard of care approach. But what we do know is that when a safety plan is created and performed with high fidelity to the model, and then when it's augmented with follow-up services like phone calls after you leave the emergency department and create a safety plan, or if you engage in a skills group, those safety plans are associated with a reduced risk of suicide attempts and psychiatric hospitalizations. So ultimately, I want to kind of switch a little bit to kind of dig back into this social concept aspect. And I want to briefly touch on the 2 most supported contemporary theoretical models of suicide that can really help us further understand suicide, and specifically what I'm looking at that transition from thinking about suicide to acting on suicide. And these are particularly driving why we wanted to focus on the social aspects of safety planning. And so I'm sure a lot of you are really familiar with these 2 models, but just briefly to comment on the parts that we were focused on. So in this first image here, Thomas Joiner's model of the interpersonal theory of suicide. And what I want to draw our attention to is the concepts of thwarted belongingness, so feeling like you're alone or you don't belong, and perceived burdensomeness, that you feel like a burden on others. And those 2 together, also with the influence of hopelessness, is going to create that desire for thoughts about suicide. And then adding in that additional component of capability for suicide is going to get you to making that lethal or near lethal suicide attempt. And then similarly, in Klonsky and May's 3-step theory for suicide, I really want to focus in on these are the 3 steps to get to that suicide attempt. But again, pointing out that in step 2 is your pain overwhelming connectedness. And when these researchers were developing this theory, they're talking about any kind of connectedness. So whether that's being connected to family or friends, maybe more of those social contexts, but it also could be having connection to your job or a sports team. So it's a little bit broader of a component here. But again, this kind of concept of being connected, having that purpose and meaning in life. But my group really wanted to understand how these social aspects of safety planning and given their relevance in that transition from having that suicidal desire and moving on to a suicide attempt. So to do this, the primary purpose of this study was to estimate the rate of missingness of those social aspects of safety planning. And we really aim to understand whether the missingness of social context on safety plans differ based on demographics and diagnostic variations, as well as the potential impact on clinical outcomes. And so we looked at a sample of just over 1,600 veterans from the VA San Diego, and these plans were coded as to the absence of listed distraction contacts, so that first step, and then help contacts, that next step on the safety plan. And then we pulled clinical records to look at potential outcomes for the year after the safety plan was completed. And this is just a little bit of a breakdown of our demographics in this sample. And first of all, just to note that there are definitely some limitations here given the limited and minimal descriptors we had available to us, since this is electronic health record data. Notably that we have a binary gender category and that the racial ethnic breakdown was blurred. But overall, veterans in this sample were mostly male, and close to half identified their race as white, whereas almost 20% identified their ethnicity as Latinx or Hispanic, and our age range from 19 to 97 years old. And so these were all of the safety plans that were from this specific time window that we were looking at. Further, just over half had a co-occurring psychiatric disorder listed in their medical record, but 12% had no listed psychiatric disorder. But the most common primary psychiatric disorder was affective disorders without psychotic features. And so what did we find? We found that actually 30% of veterans were lacking one of these social contacts on their safety plan. And interestingly, 12% of veterans did list a help contact, but they also checked the box that they would not call them, even though they listed them. And specifically, we found when considering demographics and diagnostic variations that white men were the veterans that didn't list a social contact. There wasn't any effect for age or diagnosis, though. And I'm going to skip this slide just for timing, but this is kind of giving our breakdowns of our clinical outcomes findings. I think it's a little bit easier for us to take a look at this graphical depiction of this. And so in this graph along the x-axis, we have the combinations of having or lacking these different social contacts on the safety plan. And then the y-axis is the rate of clinical outcomes in that 1-year follow-up period. And so what we can see is that lacking a help contact, that kind of third group there, increase the rate of a suicide attempt or death by suicide over 2 times. And that 2 times rate also we saw for psychiatric inpatient hospitalizations and emergency department visits. Further, in that last group there, veterans who did not list either a distraction or a help contact, so both were missing, were 2.45 times more likely to make a suicide attempt or die by suicide in that next year. So lacking any distraction or help contact on the safety plan more than doubled the risk in the next year from that transition from thinking about suicide to attempting or dying by suicide. And lacking those crisis contexts, those social contexts, also really increased the risk of hospitalization and ED visits. So putting this all together, this study really adds to the importance of completeness of a safety plan, such that the lack of completeness, particularly with those social contact steps and connecting with people to help manage your isolation or your distress related to suicidal thoughts, is highly relevant to suicidal behavior outcomes and crisis service uses. And there are several non-mutually exclusive possibilities as to why these social contexts might be lacking. And one possibility is that veterans have these social contexts, but providers neglected to record them. So we decided to take a look at this, and we found that there doesn't seem to be a rate of difference by the different types of providers completing these safety plans. So another possibility might have been that veterans do have social contacts but don't want to list them. But you might remember that those 12% of veterans who they did have an option to list their health contact, but that they wouldn't actually call them in a crisis. And we found that there weren't any differences among that group compared to the veterans who listed a health contact and would contact them in a crisis. So more likely, we're thinking that there are some veterans that have social contacts, but they have this belief or perception that they have no one to list, maybe that thwarted belongingness, or that a social contact wouldn't want to be listed on their safety plan. And potentially the most likely situation and explanation of this is that some veterans are just really highly socially isolated, and that we know that this is an increased risk for suicide. So whether that's the true or perceived lack of social contacts, as well as the desire to even use these social contacts in a suicidal crisis, it's really consistent with these maladaptive belief systems that are embedded in these theories that we know support that transition from ideation to action and acting on the following through on a suicidal behavior. And so that could lead to a lot of different treatment implications for this. This study is, of course, not without its limitations. Just to highlight some here, that we were only looking at one site within the VA. And if you've heard, when you've seen one VA, you've seen one VA. Importantly, too, is that these outcomes are all derived from the clinical record. And so importantly, too, that this is probably underestimating the amount of suicidal behavior that has been documented in the clinical record. And then just to highlight again that this was kind of the presence or absence of social contacts is certainly a coarse measure to determine this predictor. And so this definitely left us with some lingering questions, such that what can providers say when a veteran says, I don't have anyone to list on my safety plan? Or does that leave the provider wondering, do they really have no one to call? What interventions could we do to help build social contacts for veterans? And if they do have these social contacts, how can we integrate them into safety planning? And just briefly, kind of our future directions and next step is that I was recently awarded a career development award through the VA for a 5-year grant to develop and determine the feasibility and acceptability of a recovery-oriented, suicide-focused tool to be delivered by peer specialists in the VA that's really particularly targeting veterans with serious mental illness to enhance safety planning in that group, given that they're so high risk. So if you want to learn more about that and kind of the next steps on where we're taking this research, I would certainly recommend coming to, we have a symposium tomorrow at 8:45 Pacific, looking at including persons with psychosis and suicide prevention research, and particularly for my talk, how that relates to safety planning. So definitely encourage all of you to join that, and also just to acknowledge and thanks to my co-authors and just the symposium at large. It's been really fun to be here, and their sponsors, and please feel free to contact me if you have any questions or want to connect. Thank you.
All right. Good afternoon. My name is Jonathan Sung, and I work on an evaluation team within the Injury Center at the Centers for Disease Control and Prevention. And I'll let my colleagues introduce themselves.
Good afternoon. My name is Tarabia Womble, and I also work on an evaluation team within the Injury Center at the Centers for Disease Control and Prevention.
And hello, everyone. My name is Darnisha Tabor. I work as an evaluation fellow at the CDC Foundation in the Non-Infectious Disease Department. And I'll pass it back over to my colleague, Jonathan, to get us started.
Thanks, Darnisha, and thank you all for joining today. We will be sharing lessons learned from 3 years of an evaluation capacity building project working with veteran serving organizations. Next slide, please. So what is program evaluation? Evaluation is not just one size fits all, it's not one size fits all, but rather a set of tools and approaches that can be adopted and adapted to understand a program based on community needs, context, and resources. Evaluation can be used for many purposes. The greatest aspect about evaluation is that it has rippling effects. Evaluation holds benefit not only for a program itself, but also for its participants and their communities, program partners, and others. Next slide, please. So a bit of background. Suicide is a leading cause of death for Americans overall. VA data from 2019 showed the veteran suicide rate was 1.5 times higher than non-veterans, which equates to an average of 17 veteran suicides per day. Veteran Serving Organizations, or VSOs, provide an array of essential suicide prevention services to veterans, but often have less experience with evaluating their programs in-house. This evaluation gap can contribute to less efficient and effective programs, which can be a significant barrier in building the evidence base for effective approaches to veteran suicide prevention, which is a core component of the public health approach to injury prevention, which you can see below on the slide. Next slide, please. So in 2019, CDC collaborated with the CDC Foundation to initiate the Veteran Suicide Prevention Evaluation Demonstration Project, or VSPE, to begin to address this evaluation gap. The vision of this project is to build evaluation capacity among VSPE, among VSOs implementing programs that address upstream factors for suicide. Help VSOs understand the role that they play in an upstream public health approach to veteran suicide prevention, as well as strengthen relationships between VSOs, CDC, and CDC Foundation by enhancing the collaborations and fostering sustainability. Next slide, please. So, eligible VSPE participants must be nonprofit organizations implementing programs using one of two models to address upstream factors for veteran suicide prevention. So these upstream factors are those which impact suicide outcomes well before someone might be in crisis or in need of intervention. The two models are the community intervention model, which is a one-stop shop to connect and refer veterans to additional appropriate services on the left-hand side of the slide, as well as on the right-hand side of the slide, the connectedness model, which focuses on increasing veteran connectedness to others. Next slide, please. So to date, 14 unique organizations have participated in the project across 4 years. Here you can see some of the example projects. The unique aspect of this capacity building project is that the project does not fund them to do work that we think they should do. Instead, this project empowers VSOs to engage in bi-directional learning to identify what they need to learn about their programs in order to improve and enhance their ability to serve veterans. Next slide, please. And I would like it to pass it back to my colleague Taribia to talk through the methods.
Thank you, Jonathan. The purpose of our mixed methods evaluation was to assess the extent to which the VSPE project has achieved the short-term and intermediate outcomes of the project. You can see our evaluation questions here. Across all years, semi-structured impact interviews were conducted 6 months post-participation with former grantees to understand more about the impact of VSPE on their programs. In year 3, recipients also participated in a CDC evaluator self-assessment used to assess their evaluation knowledge, skills, and self-efficacy following the completion of the program. We are currently in year 4 of the program, so evaluation for this year is forthcoming. Next slide, please. Across years 1 through 3, we identified 4 main themes, as you can see here. We will walk through each theme in the subsequent slides. Next slide. VSOs reported strengthened partnerships and collaborations due to participation in this project, which was often a result of being able to better communicate what the organization does and how this aligns with their shared goals. VSOs also discussed new or improved approaches to stakeholder engagement, including how they considered and defined their stakeholders, their approach to engagement, and how they utilize stakeholder feedback. VSPE grantees have partnerships with local, state, and federal entities that represent many geographic locations and sectors, including health, education, housing, legal, employment, recreation, and other intersecting groups. Next slide. Grantees noted an increase in funding and visibility due to their involvement in the VSPE demonstration project. One of our grantees from years 2 and 3 explained that they were able to raise more money in 2020 than they had in the 3 years prior combined, which they felt was a direct result of this project. Similarly, other VSOs described increased credibility and new opportunities to have a seat at the table based on engagement in this program. This credibility was attributed to either using data more effectively or providing needed data to fill in gaps for partners. VSOs also spoke to the benefit of increased visibility for learning as an organization and broadly within the community to share insights with subject matter experts and speaking at different venues. All right, next I will pass it to my colleague, Darnisha.
Thanks so much, Tarabia. I'll be speaking to the program improvements within VSOs. Many VSOs talked about their involvement with VSP as it related to their improved programs. As shared in this slide by a VSO grantee, Veterans Aren't Hamburgers, we had to look at more than just the total number served. Initially, this VSO recipient relied on metrics such as counts of open and closed cases to determine quality and success. However, by moving from tracking metrics to truly evaluating their processes to make needed changes, they not only improved the support and services they currently provided for veterans, but the organization also became more agile and flexible, with the ability to shift the work as necessary to meet the other needs of the veterans and families that they were serving. Other VSOs shared similar outcomes, reporting that their strength in evaluation skills improved their programming as well as strengthened their relationships with veterans because they were able to better understand them using the results produced from their evaluations. The majority of VSOs reported that their increased and sustained evaluation capacity enhanced their communication strategies within the organizations and deepened connections and collaboration with external stakeholders, such as community organizations and other government officials. Furthermore, increased evaluation capacity also improved their advocacy efforts because many organizations had developed ways to better communicate the impact of their work. In alignment with the shared quote on this slide, many VSOs noted that improved advocacy was unexpected, but nonetheless, developing the ability to better understand, communicate, and meet the needs of veterans demonstrated that evaluation had become an instrumental component of their work. In year 3, VSOs completed the CDC Evaluator Self-Assessment, a survey to assess a change in their self-reported skills. The findings revealed that VSP strengthened the evaluation skills and capacity of participating VSOs, which is in alignment with the 4 themes communicated earlier in the presentation. All VSOs reported a high or full ability implementing evaluation skills, such as working with stakeholders to address negative or unexpected findings, and also tailoring a presentation of evaluation findings to multiple audiences. In addition, 83% of VSOs reported a high or full ability to use evaluation skills, such as describing the benefits and uses of program evaluations to others and creating a program logic model. The development of these skills not only demonstrate the effectiveness of the VSP project, but it also supports the program's goals of empowering VSOs to evaluate their programs, adapt their programming to meet the needs of veterans, and communicate with internal and external stakeholders more effectively. And now to wrap up our presentation, I'll pass it over to my colleague, Tarabia.
Thank you, Darnisha. So in conclusion, our findings demonstrate that participating VSOs have experienced continued benefits of evaluation capacity built through the VSPE program. The collaboration and bidirectional nature of VSPE has strengthened VSO partnership as well as CDC's own approach to engaging in this collaborative space. VSOs evaluating their programs now only allows them to improve their work, but also to contribute to the evidence base of what works to prevent veteran suicide, all of which builds toward fewer veteran lives lost to suicide. Thank you all so much for the opportunity to share, and this concludes our presentation. If you have any questions, we can move into that part of the presentation as well. Okay, well, I don't see any questions in the chat. So thank you all.
I think there's one higher up for maybe Caring Letters project. Yeah.
I think I'm muted still.
We can hear you.
We can hear you.
Oh, great. Okay. I had a little thing saying the host had muted me. I think there was one about the Governor's Challenge team for VCL Caring Letters. And Dr. Rieger, I'm happy to take a pass at this, but I know you also presented that at the Governor's Challenge. And so please hop in here. We do present at the Governor's Challenge meetings about the VCL Caring Letters project in order to sort of share both about our implementation and then also sort of where we're going in terms of evaluation. And, you know, we really feel like sharing the model and what we've done in terms of implementation can be really value added. And so we're excited to share it in that forum and to sort of get the word out about what we've done. Dr. Rieger, anything to add there?
Yeah, I'll just say part of the comment I think is about getting local resources to the folks. The Veterans Crisis Line does refer folks who would benefit from local resources to the local VA. So that actually is built into the model already. I do think there's an interesting point here, though, about the Caring Letters intervention. I think the field is kind of struggling with the potential of the reach of the intervention with sort of how far you can stretch the standardization of the intervention. And I think the two presentations we had today on the topic are great examples of the benefits of really personalized cards that are creative and innovative. But those folks got one, and it's hard to do that on a mass scale. Our intervention is mass scale, templated, and the cost and impact of adding the state resources, well, then you need to update them, keep them updated, how many resources from each of the 50 states synced with addresses and the printing contractor. We have learned that any small change that adds complexity is just magnified exponentially in our kind of an intervention. So I think it's going to be really important for the field to figure out the costs and benefits of these different versions of the intervention.
Well, I just say it was an honor to present along these incredible folks here. So I just have to say thank you all so much in the audience and my co-presenters. It was such a treat to be able to do this. So thanks to the folks with SRS as well for making this happen. It's pretty special. Hopefully we can do this next year and maybe in person. It'd be wonderful to see you all. And yeah, please reach out and let's get some collaborations going. It'll be great.
Agreed. Thanks, everyone.
Take care. Bye.
Thank you.
Thank you.